Good afternoon, everyone, and welcome to Grand Rounds. It's my great pleasure today to introduce one of my colleagues, Dr. Laeeq Malik. Dr. Malik is one of the senior oncologists in the Canberra Hospital Medical Oncology department. He does have a specialty interest in the treatment of genitourinary cancers as well as breast cancer, and today he's going to be talking to us about hormone-sensitive prostate cancer.
Thanks very much, Nicole, for kind introduction. Can you hear me okay? So I gave this talk in 2018, I think, while I was asked to do another grand round this year after a few years. I thought I'll do prostate cancer again because it has changed altogether since my last grand round presentation. So while preparing this, I went through my previous slides. Okay, and I found that there was just one slide which I could borrow from last presentation, and that's this one. So this is diagnostic landscape for prostate cancer. Prostate cancer back in 2018 was relatively simple. It was PSA, recurrence-only prostate cancer, where there is no signs of prostate cancer on conventional imaging, but the PSA is high, or patients would have disseminated widespread prostate cancer. And the patients can be either early on in their journey, what we call hormone-sensitive prostate cancer. In those days, it was castrate-sensitive prostate cancer, or they would become resistant and they would be hormone-resistant prostate cancer. But the diagnostic landscape has become much more complicated since then. And just quickly walking you through, patients, when they're diagnosed with prostate cancer, they may have localized disease, or they may have metastatic disease, we call de novo metastatic disease. Localized disease is treated with surgery, radiation, androgen deprivation therapy, often combination of these. And some patients, they are cured, while some patients, unfortunately, they recur sometime in future, and they either have non-metastatic hormone-sensitive prostate cancer, or they have metastatic hormone-sensitive prostate cancer. Now, those patients who have non-metastatic hormone-sensitive prostate cancer, they can either progress to metastatic hormone-sensitive prostate cancer or non-metastatic hormone-resistant prostate cancer. And metastatic hormone-sensitive prostate cancer now is divided into oligometastatic disease and polymetastatic disease. And it's quite useful to know how many metastases patient has, because the treatment can vary. And we'll go through that. And metastatic hormone-sensitive prostate cancer, after some time, becomes metastatic hormone-resistant prostate cancer, and that progresses to late-stage prostate cancer. So every patient with prostate cancer you see would somewhere fall in this journey. So each of these stages of prostate cancer have the different treatments, and it will take me a day to go through all of this today. So my talk today is focused on metastatic hormone-sensitive prostate cancer, particularly focuses polymetastatic disease, but we'll quickly touch base on oligometastatic disease as well. So before we get started, we'll just quickly go through the terminology so that we all get used to this, because we'll be using some of these terminologies later during the presentation. So ADT stands for androgen deprivation therapy. And in the olden days, we used to do this by bilateral orchidectomy. And in the last 30 years plus, we're using one of these agents. These all are equally effective. They're given either subcutaneous or intramuscular, and they are either given once a month or every 3 months or every 4 months or every 6 months. MHSPC is metastatic hormone-sensitive prostate cancer. Docetaxel and cabazitaxel, they are intravenous chemotherapies we use for prostate disease. And then we'll be talking a lot about NHA, novel hormone agents. They are second-generation anti-androgen agents, and there are 4 of them which are available and reimbursed here: abiraterone acetate, apalutamide, darolutamide, and enzalutamide. And there is some emerging data about PARP inhibitors and radioligand therapies in metastatic prostate cancer. Quick definitions, we'll be using again these during our presentation today. High volume disease refers to patients who have 4 or more than 4 bone metastases, or they have visceral metastases, and these patients are called high volume disease. They have poor prognosis as compared to patients who have low volume disease. Low volume disease is if you have less than 4 bone metastases and no visceral metastases. We also use this terminology, high risk disease, which basically means that you should have 2 of these 3 to be called high risk disease. Gleason score 8 or more prostate cancer, at least 3 bony lesions, or visceral metastases. And if you don't meet the 2 of those 3 criteria, your disease is low risk disease. While we got the definitions and terminology clear, let's talk about drug development in metastatic prostate cancer. So the way we develop drugs in prostate cancer is that we first research and explore the role of new agents in hormone-resistant prostate cancer. So that's the group which where your drug development starts first. And once your drug is considered to be safe and efficacious and gets approved by the regulatory authorities in hormone-resistant prostate cancer, then those drugs move to hormone-sensitive prostate cancer. So then you have trials demonstrating efficacy in that subgroup. And again, once you have regulatory approval in that setting, and historically, then drugs get research in localized disease. In the last 2 or 3 years, maybe there are trials which are running in parallel, looking at a novel agent in hormone-sensitive prostate cancer at the same time in localized disease, but that's the historical paradigm. So we have, I'm sorry, it's just I'm standing in front of that slide. I can't get rid of myself from here, but I'll quickly walk you through. So these are the agents we have in hormone-resistant prostate cancer, some early generation androgen receptor inhibitors, cabazitaxel, docetaxel chemotherapy, and then abiraterone acetate and enzalutamide, apalutamide, darolutamide, and PARP inhibitors, I think P stands for, and radioligands. Docetaxel was the first drug after improving outcomes in hormone-resistant prostate cancer. It was researched and subsequently approved in hormone-sensitive prostate cancer. Subsequently, the other 4 agents, which are novel hormone agents, they have moved from hormone-resistant prostate cancer and hormone-sensitive prostate cancer. And we have these agents currently being researched with some very interesting and impressive data coming in localized prostate cancer, the patients who are treated with curative intent. So I just want to quickly go through the oncology clinical trial endpoints, which may be a bit different than the endpoints used in other specialties. Overall survival is the gold standard endpoint, which usually is the endpoint in phase 3 trials. But it's the endpoint which is most difficult to meet because it requires a longer follow-up. And then it's also impacted by the subsequent treatments patients receive for their cancer. And also depends on the trial design where there is crossover effect. And hence, overall survival is quite difficult to prove with any novel agent. As a result, a lot of phase 3 and some phase 2 trials, they use progression-free survival, which is also called failure-free survival. And that's defined as time from randomization into a trial till disease progression or death. And in some cancers, including prostate cancer, we consider progression-free survival as a surrogate endpoint. It's not diluted by subsequent therapies or crossover effect, and it's easier to measure and requires a shorter follow-up. Objective response rate is the primary endpoint in phase 2 trials and usually a secondary endpoint in phase 3 trials. And basically it means the proportion of patients who have partial response, which means 30% tumor shrinkage, or complete response, which means complete disappearance of cancer. So those two patients combined together, those two groups, we call it objective response rate. And then safety is usually secondary endpoints in phase 2 and phase 3 trials, and dose-limiting toxicity, which is a safety thing, is usually the primary endpoint in phase 1 trials. And quality of life, a lot of new oncology trials are having quality of life data in phase 3 setting, and it's normally a secondary or exploratory endpoint. So while we got the terminology and definitions and endpoints out of the way, let's dive into metastatic hormone-sensitive prostate cancer. So Dr. Charles Higgins was the first, he was the American urologist who was the first guy to propose that removing androgens can improve control of prostate cancer. And he performed the first bilateral orchidectomy in prostate cancer patients and demonstrated improvement in symptoms by removing the source of androgens. He also subsequently did bilateral adrenalectomy and demonstrated improvement in prostate cancer control. So he was awarded Nobel Prize in Medicine in 1966 for his work with androgen deprivation therapy. And it was many years later, I think in 1980s, when we started having pharmacological agents to suppress androgen production, so androgen deprivation therapy, and bilateral orchidectomy is uncommon these days. So you will find several articles published, including case series of the patients he treated in those days in 1940s with bilateral orchidectomy. So for decades, we have been using androgen deprivation therapy to treat metastatic hormone-sensitive prostate cancer. However, in 2015, the practice changed when we realized that if you add chemotherapy in early stages of prostate cancer, that's hormone-sensitive prostate cancer, you can improve outcomes, including survival of the patients. And then as the other agents, the novel hormone agents, they found their place in hormone-resistant prostate cancer. They were subsequently researched in hormone-sensitive prostate cancer, and they improve outcomes, and they have become available and approved. So we'll try to treat 4 patients today in our presentation as well. So this is an 80-year-old gentleman who has Gleason score 8 prostate cancer that recurred about 4 years after his radical radiotherapy to prostate. His PSA was 12 with a doubling time of 4 to 6 months. And his PSMA PET scan showed that there was recurrence in the prostate, and there was oligometastatic disease in the sacrum. It's right there. There's another patient, he's 73, and he has recurrent Gleason score 8 prostate cancer, metastatic hormone-sensitive, with a PSA of 90, and his PSMA PET scan shows multiple nodal areas of uptake, including para-aortic and retroperitoneal and maybe retrocrural lymph node and urocable lymph nodes. So several lymph nodal stations involved. And then this patient, 65-year-old gentleman who has higher grade prostate cancer with a PSA of 1200, and his PSMA PET scan shows prostate cancer everywhere, not visceral metastases, but all the bones. So ribs and spine, extensive prostate disease, and this is de novo prostate cancer. And the 4th patient is a 53-year-old gentleman who has metastatic hormone-sensitive prostate cancer, again, de novo disease, but not a high PSA, only 20. And he also has widespread skeletal disease, and there is evidence of liver metastases on his diagnostic baseline imaging. And he has some pancytopenia on his routine bloods. So we'll come to these 4 patients after going through some evidence and discuss their management. This study is what changed the treatment landscape for metastatic hormone-sensitive prostate cancer after using ADT for decades. So this study was led by Chris Sweeney, published in New England Journal of Medicine. So this is teaching from New England Journal of Medicine today. Many of the publications are from New England Journal. So the study had 790 patients with metastatic prostate cancer. They were all fit patients with good performance status and histologically confirmed disease. And they were randomized 1-to-1 to receive androgen deprivation therapy alone, which used to be standard of care at that time, or androgen deprivation therapy with 6 cycles of docetaxel chemotherapy. And the primary endpoint of the study was overall survival. So after a follow-up of 28 months, the study demonstrated improvement in median survival in patients who had chemotherapy, where it was 49 months, as compared to patients who had ADT alone, it was 32 months. So there was about a year and a half, 17 months improvement in overall survival. Hazard ratio was 0.60, but that was in high volume disease. As I mentioned earlier, 4 or more bone metastases or visceral metastases is called high volume disease. In patients who had low volume disease, median survival was not reached after a follow-up of 28 months. So with the longer follow-up, in total about 53 months, the benefit persisted in high volume disease. Median survival with chemotherapy remained 51.2 months and 34 months with ADT alone. So again, about 17 months difference in survival, but no benefit in low volume disease, where with chemotherapy, median survival was 63 months and not reached with ADT, ADT's androgen deprivation therapy alone. So as I mentioned earlier, if you have low volume disease, you do normally better than high volume disease. It's a predictor. And also the chemotherapy didn't demonstrate survival advantage in these patients. So the practice since 2015 has been like this, that when we see newly diagnosed hormone-sensitive prostate cancer and the patients have high volume disease, we offer them a combination of androgen deprivation therapy and docetaxel chemotherapy. And if they have low volume disease, then usually it's androgen deprivation therapy alone. Although you can consider docetaxel chemotherapy in selected patients with low volume disease if they're fit and they have high risk disease, which is different from high volume disease. Now let's explore the role of novel hormonal agents in metastatic hormone-sensitive prostate cancer. So these are oral anti-androgen agents. They're second-generation anti-androgen agents, and including abiraterone acetate, enzalutamide, apalutamide, and darolutamide. They have just become available and reimbursed on PBS in Australia in the last 12 months. The abiraterone acetate has just become available and reimbursed just a month ago, 2 weeks ago, so that's pretty new. Enzalutamide been around for 6 months for this disease, and apalutamide and darolutamide also 6 to 9 months. So let's start with abiraterone acetate and metastatic hormone-sensitive prostate cancer. This trial was a large phase 3 trial with 1,900 patients, which is called STAMPEDE trial. Looking at role of abiraterone acetate in hormone-sensitive prostate cancer. So the way abiraterone acetate works is that testosterone is produced by testes and adrenal glands, and this testosterone is converted to its active metabolite, the most common and active metabolite called dihydrotestosterone, by 5-alpha reductase, and abiraterone inhibits the conversion of testosterone to testosterone to dihydrotestosterone, so it blocks that step. So in STAMPEDE phase 3 trial, there were 1,917 patients with good performance status, histologically confirmed prostate cancer. Majority of the patients were metastatic, but they also had a good proportion of patients with locally advanced disease who recurred post-radical therapy, but not metastatic, so M0 disease. And these patients were randomized 1-to-1 to receive ADT alone, the standard of care at that time, or ADT plus abiraterone acetate. And the primary endpoint was to demonstrate improvement in overall survival. These are some of the baseline characteristics of the patients. So median age 67 and the median PSA diagnosis 56, and 53% patients had metastatic disease and 47% patients had non-metastatic disease, but locally recurred post-radical treatment, and Gleason score was high in 75% patients. With regards to overall survival, the primary endpoint in metastatic disease, the median survival not reached in this group, but 3-year survival rates were looking better, 76% for ADT only arm, and 83% 3-year survival rates for patients who had androgen deprivation therapy with abiraterone acetate, and hazard ratio was 0.61. Failure-free survival, which is same as progression-free survival, was also improved in this group. 3-year rates were 45% with androgen deprivation therapy, while abiraterone acetate improved that to 75%. And hazard ratio was looking very impressive, 0.31. In patients who had non-metastatic disease, there was, again, median survival not reached. There was no significant benefit there, but progression-free survival was better in these patients. Hazard ratio quite impressive, 0.21. With regards to adverse events, the incidence of grade 3 and 4 adverse events. Grade 3 and 4 adverse events are moderate to severe adverse events. So the incidence of that was slightly higher, but 47% in combination compared to 33% in androgen deprivation therapy alone. But it was mainly in the form of hypertension and some transaminitis. And the incidence of that was quite low, less than 10%. I thought by now most of you would be sleeping, and just to wake you up, and those of you who follow cryptocurrency, the Bitcoin has come to over 100,000 and there's a very nice article in the Wall Street Journal. So moving from New England Journal to Wall Street Journal, but I promise we'll get back to New England Journal. And I just realized that the Cancer Council of New South Wales, they do accept donation in cryptocurrency in case if you want that. But I'm sure Nicole won't let me talk too much about that. So I'll move back to prostate cancer. So what we saw with the abiraterone acetate was that there was improvement in progression-free survival in metastatic and non-metastatic patients, and some signal of survival benefit in metastatic patients, but not in non-metastatic patients. Obviously, we need longer follow-up. So this is the second agent called enzalutamide we use for metastatic hormone-sensitive prostate cancer. And there are 2 studies, which both phase 3 trials, which explored the role of enzalutamide in hormone-sensitive prostate cancer. The first trial was published in New England Journal of Medicine. This was of a local trial, local cooperative group trial. So it's NZUP, that stands for Australian and New Zealand Urogenital and Prostate Cancer Trials Group. And the study is called ENZAMET trial. And the second study is called Archer study. So again, going back to the mechanism of action. So once the testosterone gets converted into dihydrotestosterone, this dihydrotestosterone binds with androgen receptor by displacing HSP70 and HSP27 proteins. And this complex then translocates to the nucleus where this complex binds with androgen receptor element and act as transcription factor to signal downstream elements. And this translocation of the complex into the nucleus is blocked by enzalutamide, as well as the other 2 drugs I'm going to talk about, apalutamide and darolutamide, later on. So this study was a large randomized phase 3 study, or open label, had 1,126 patients who were randomized to receive androgen deprivation therapy plus standard of care, or androgen deprivation therapy with standard of care and enzalutamide. The standard of care changed because while the study was in progress, the docetaxel became standard of care in high volume patients. So they added docetaxel as well. So certain patients got triplet and certain patients got doublet therapy. The primary endpoint of the study was overall survival as well in the study. And when they published the results, the follow-up was only 34 months, and hence median survival not reached in either of those two groups. But the 3-year survival rates were looking good, 72% with standard of care arm and 80% 3-year survival rates with enzalutamide with androgen deprivation therapy. And if we look at the forest plot, most of the subgroups, they benefited from adding enzalutamide, particularly to focus on the volume of disease. There was a benefit seen in patients with low volume disease as well as high volume disease. In low volume disease, the hazard ratio was 0.43. So that's different than what we saw with docetaxel chemo, where the benefit was demonstrated in high volume disease, but not in low volume disease. So with regards to progression-free survival, whether we look at progression-free survival through PSA or clinical progression-free survival, we can see improvement, hazard ratios of 0.39 and 0.40. And all subgroups of patients, they had prolonged progression-free survival if they received enzalutamide. The adverse events, about 49% patients who had enzalutamide, they had moderate to severe adverse events as compared to 35% patients who had standard of care only. And these adverse events included mainly some hypertension and fatigue. The incidence was less than 10%. And also number of patients who discontinued enzalutamide, the number was higher than those patients who discontinued androgen deprivation therapy, so a bit higher there. So again, the side effects look pretty manageable if it's given to carefully selected patients. So the second study, which looked at enzalutamide in metastatic hormone-sensitive prostate cancer, was Archer's study. This was again a phase 3 trial, but it was a double-blind, placebo-controlled study of 1,150 patients with metastatic hormone-sensitive prostate cancer randomized to receive androgen deprivation therapy with placebo or enzalutamide. And the primary endpoint of the study was to demonstrate radiographic progression-free survival, and overall survival was the secondary endpoint. So the results were presented after a follow-up of 14 months, median follow-up, and median progression-free survival was not reached for enzalutamide compared to placebo with ADT, where it was 19 months. And overall survival not reached. And again, I'm sorry, you can't see this forest plot very well. I'm standing right there. But you can see that pretty much all subgroups of the patients, they had improvement in their progression-free survival if they receive enzalutamide. So moving to the apalutamide, which is another novel hormone agent, been approved for this disease. Apalutamide study was published in New England Journal of Medicine, and it works pretty similar to, same target, similar to enzalutamide. It prevents the translocation of that complex into the nucleus and stops it from acting as transcription factor to signal downstream targets. So the study is Titan study. It was, again, it was phase 3, but also double-blinded, placebo-controlled, with 1,052 patients who had prostate cancer, and the patients having good performance status, randomized to receive androgen deprivation therapy with placebo or androgen deprivation therapy with apalutamide. And the primary endpoint, so it had two co-primary endpoints, overall survival and progression-free survival. And when they presented results, the follow-up was only 22 months. And at 22 months follow-up, the progression-free survival median was 22 months for androgen deprivation therapy only, and was not reached for apalutamide arm. But 2-year progression-free survival rates were looking impressive, 47% versus 68%. And similarly, with 22 months follow-up survival, Median survival not reached for either of those two arms, although 24-month survival difference was already about 10% with hazard ratio 0.67. We look at the forest plots, and for progression-free survival or overall survival, you see clear benefit in all subgroups, including patients who had low volume disease versus high volume disease. Low volume disease hazard ratio 0.36, similar to what we saw with enzalutamide before. So adverse events, there was increased incidence of adverse events, particularly hot flush, fatigue, pruritus, rash. This drug does cause rash, which we don't see with enzalutamide. But again, the incidence of moderate to severe which is grade 3 adverse events, that was low, and in practice, we considered it manageable. So in the last 15, 20 minutes, I've gone through doublet therapy and demonstrating improvement in progression-free survival and some very good signal towards improvement in overall survival. But how about we combine chemotherapy and a novel hormone agent plus androgen deprivation therapy? So that's a triplet therapy. So that has been looked at recently. And the first study which looked at this was called Arison's trial. So it published in England Journal of Medicine 2022. But the treatment has now come on PBS about 3 months ago. So darolutamide is similar to the other two agents. It stops the complex translocating into nucleus. And this, it was a phase 3 double-blind placebo-controlled trial, had patients who had good performance status and histologically confirmed prostate cancer, randomized 1-to-1 to receive doublet therapy, which means androgen deprivation therapy plus chemotherapy, 6 cycles, and then continuing androgen deprivation therapy after that, or triplet therapy, which is adding darolutamide. And the primary endpoint of the study was to demonstrate improvement in overall survival, but it also had some secondary endpoints, including time to symptomatic progression and skeletal event-free survival and time to castrate resistance. Baseline characteristics, well-balanced, and median age 67. So these were fit patients with majority of them had Gleason score 8 prostate cancer, about 77%, and 85% of them had M1 disease, so metastatic disease. And the study had a follow-up, 43 months, a bit longer follow-up than the previous drugs which we talked about. And at a median follow-up of 43 months, we saw median survival of 48 months in patients who had doublet therapy versus not reached with triplet therapy, and hazard ratio 0.68 and p-value significant. So here we have subgroup analysis, a high volume and low volume disease. Benefit was mainly seen in high volume disease, where median survival was still not reached in triplet arm versus 42 months with doublet arm, and still the same hazard ratio. Median survival not reached for either of those two arms in low volume disease, although the hazard ratio was similarly good, 0.68. These are secondary endpoints. They probably are easier to see on this slide. So time to castrate resistance with doublet therapy was 19 months versus not reached with triplet therapy. Time to symptomatic progression or pain progression improved from 27 months to not reach. And symptomatic skeletal event-free survival also improved from 39 months to 51 months. So these are all secondary endpoints which improved with triplet therapy compared to doublet therapy. Surprisingly, with triplet therapy, there was not a lot increased incidence of adverse events. Grade 3, which is moderate to severe, adverse events rate were similar, 35% with doublet and 38% with triplet therapy. And again, hypertension and transaminitis, what we have seen with other agents earlier. Quickly, this is another trial looking at triplet therapy versus doublet therapy called Peace One trial from Lancet 2022. The trial had it was a phase 3 and open label study, and it had a complex design because there was some radiation arm as well, which we'll exclude. So the trial started as exploring the role of abiraterone in hormone-sensitive setting in addition to androgen deprivation therapy. But then the standard of care changed, and docetaxel was widely used in hormone-sensitive. So they added docetaxel as well, so it became triplet versus doublet. And so when we look at the patients who had triplet therapy, which majority of the patients had, so majority of the patients had docetaxel, so doublet versus triplet. The triplet is indicated in red line here and doublet in blue line. So this is progression-free survival with hazard ratio 0.50, so 50% reduction in risk of disease progression, and with regards to survival, hazard ratio was 0.75. The subgroup analysis showed that the progression-free survival benefit with triplet therapy was seen both in low volume and high volume disease. But with regards to survival advantage, it was mainly in high volume patients who had triplet therapy. In low volume patients who had triplet therapy, the hazard ratio for survival was 0.83 compared to high volume where it was 0.72. So, while we have gone away from ADT monotherapy and been doing doublet therapy and now moving to an era where we're using triplet therapy. So in 2024, does everybody needs doublet therapy and triplet therapy? These drugs do have side effects and cost involved as well, or there are some patients where androgen deprivation therapy alone is still good enough, and we don't have to escalate their therapy. In my opinion, I think that there are still some patients who would benefit from androgen deprivation therapy alone, and these are elderly patients who have disease which is low grade and low risk and slow doubling time of PSA, and they don't have HRR mutation or BRCA mutation, and they have multiple health problems and poor performance status, where I think ADT alone is a reasonable therapy even after going through all of the data. So quickly, I want to mention this study that in patients who have metastatic hormone-sensitive prostate cancer and they have oligometastatic disease, we do consider sometime ablative radiotherapy, so SBRT, to the targeted metastatic sites. Previously, all the data was in a retrospective setting, and but for the first time, we have a prospective. It's still single institutional, but it's a prospective data from this trial called Transform trial. And we had some of our colleagues from Canberra who also participated in this study. So this study had patients who had recurrent prostate cancer with up to 5 sites of metastases. They all had treatment to their primary in the past. And they were, and the site of metastases were either bone or lymph nodes, and they were treated with SBRT. And the idea was to delay the commencement of systemic therapy or escalation of their treatment. And they had a follow-up of 24 months and a median time to treatment escalation was 27 months. So if you radiate limited metastatic sites, you can avoid going on to ADT for maybe 2 years or so. And here we can see it's interesting endpoint. The way I see is it's ADT free interval, or they call it treatment escalation free interval. So number of patients who were treatment escalation free after SBRT at 2 years, they were still looking pretty good, except small number of patients who had they had hormone resistant disease, where it was only 38% patients at 2 years they were treatment escalation free, compared to hormone sensitive where it was 52%. Number of sites didn't matter. If you have 1 to 3 sites or 4 to 5 sites, still more than half of the patients, they didn't need treatment escalation or ADT commencement. So we do consider this as an alternate option instead of going on to androgen deprivation therapy. Waterfall plot showing PSA responses after SBRT to oligometastatic sites. 75% patients had a PSA improvement, including some patients who had undetectable PSA after this. So quickly in the last 2 minutes, I'm sorry, Nicole, I'm over time. Those 4 patients we decided to treat early on. So this patient has oligometastatic prostate cancer. He's 80. I think observation is not something I would recommend. His PSA is going up reasonably fast, about 4 to 6 months. We can't put him through SBRT because he has recurrence in his prostate as well that was treated with radiotherapy 4 years ago. So I would just do ADT alone and hope he would do all right for some time. While this patient who has metastatic Gleason score 8 prostate cancer with a PSA of 90 and few health problems there and has extensive lymphadenopathy from his disease, he's someone I would recommend ADT plus novel hormone agent based on the data we have seen before. While this 65-year-old gentleman who has de novo high Gleason score prostate cancer with a PSA of 1200, he's someone I would give triplet therapy. He's going to do very bad. So you have best shot giving him everything now. And this gentleman who has unusual disease, has low PSA of 20, liver metastases at the time of diagnosis, which is unusual. His liver biopsy showed that he had small cell variant prostate cancer. And so he needs a different management plan, which is platinum-based chemotherapy. So just last 2 slides. The future looks like this. With widespread use of genomic profiling in prostate cancer. So the future treatments and the future clinical trials are looking at genomic profiling and then using agents based on the results. So we would be, we are having trials which are looking at, you stress me out. So, I'm sorry. So we have trials which are looking at CDK4/6 inhibitors in addition to the doublet therapy if you have RB intact or immunotherapy in patients with MSI high or using chemotherapy in triple negative prostate cancer. So there are 114 trials which are currently in progress in metastatic hormone-sensitive prostate cancer. Out of those, 30 trials are randomized phase 3 trials in hormone-sensitive settings. So this space is going to change in the coming years. That is my last slide. Thank you very much.
Thank you very much, Laeeq. That was a wonderful overview of hormone-sensitive prostate cancer. So now, first of all, do we have any questions from the audience? Yes.
Thanks, Laeeq. See, in these trials you presented, they use multiple endpoints like PSA progression, clinical progression, radiological progression. In clinical practice, which one is most important when you consider when you deciding to change treatment?
I think we look at all of those. It's PSA progression, symptoms, which is symptomatic progression, and radiographic progression. But I think the clinical practice is, as you know, different from the clinical trials. So it's usually symptomatic and PSA progression we go. And usually they have radiographic progression anyway at that time.
Like, I think you did a nice job of showing us that, you know, obviously you think about the disease, high volume versus low volume and the risk and things and tailor the treatment accordingly. I was just wondering, and as you're pointing out, not everyone needs triplet therapy and it is quite intensive. I have to say, I was wondering whether those trials have, you know, haven't asked too much about vasomotor side effects and things. They didn't mention hot flushes that much. And I think probably in clinical practice, you see that more in your patients. With the, I might have missed that, but with the triplet study you showed with the androgen deprivation therapy, docetaxel, and then the novel agent, the darolutamide, with, I presume the darolutamide was then continued until progression. And then in the control arm, I was wondering, did they start that when there was obvious, you know, progression, like radiologic progression, definite metastatic disease, or just PSA rise? Because you kind of wonder, what would have happened if it was just started with PSA rise, and would there have, you know, is there any way we could avoid adding the novel agent in for longer? So just wondering what the control was there.
So in the control arm, they had 6 cycles of docetaxel in addition to androgen deprivation therapy, and then they continued androgen deprivation therapy alone till they had radiographic progression. And at that time, they recommenced a novel hormone agent, and they did not specify whether it has to be darolutamide or it could be one of the others. So it was physician's choice. So all these patients went on to receive novel hormone agent once they became hormone resistant, which is at the time of progression. So when you have a trial design like this, it's difficult to prove survival in treatment because you are giving novel hormone agents to both of those groups. It's just that the investigational arm is getting it earlier and the other arm is getting it later. But despite that, it showed that median survival was prolonged with a hazard ratio of 0.68, which is difficult to prove, but it still proved that. But it's unethical if you don't give those patients novel hormone agents on progression.
I can't see any questions in the chat.
No.
Sorry. So I think with that, thank you very much. Like that was a wonderful overview and really nice to see the different patients and the different management approaches. So please thank Dr. Malik for us.